Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Progression in Smoldering Myeloma is Independently Determined by the Chromosomal Abnormalities, deletion 17p, translocation 414, gain 1q, hyperdiploidy, and tumor load, by Neben et al. My name is Angela Dispensieri, and I am Professor of Medicine and Laboratory Medicine at the Mayo Clinic in Rochester, Minnesota, USA. My oncologic specialty is plasma cell disorders. Neben and colleagues from the University of Heidelberg have made several important observations in a cohort of 248 smoldering multiple myeloma patients seen between November 2003 and September 2012. With a median follow-up of 3.5 years, there were 88 progressions and 6 unrelated deaths for an overall median time to progression of 5.6 years. The author's first observation was that the interphase FISH abnormalities associated with high-risk active myeloma, that is, deletion 17p13, translocation 414, and addition 1q21, confer increased risk among patients with smoldering multiple myeloma for progression to active myeloma with a hazard ratio of 2.9, 2.3, and 1.7 respectively. These aberrations were found in approximately 6%, 9%, and 30% of smoldering multiple myeloma patients studied, and were more common in patients with immunoparesis, lambda light chain restriction of their clone, a higher tumor burden, and a higher proportion of malignant bone marrow plasma cells. Their second observation was that hyperdiploidy, which was present in 43% of patients studied, was also associated with a hazard ratio of progression to active myeloma of 1.7. This finding was less anticipated because among patients with active multiple myeloma, hyperdiploidy is uniformly considered to be a good risk FISH abnormality. However, the fact that the Mayo Group published the same finding independently earlier this year lends further credence to this unanticipated finding. Hyperdiploidy, being associated with faster rates of progression of smoldering multiple myeloma, could be attributed to one or both of the following possibilities. 1. Patients with hyperdiploid smoldering multiple myeloma may spend less time in the smoldering multiple myeloma state, perhaps because they manifest symptoms earlier than other groups, making it appear like they live longer with active multiple myeloma. And 2, hyperdiploid myeloma may be more chemotherapy sensitive. That is, chemotherapy once started is more effective at controlling hyperdiploid multiple myeloma than other forms of high-risk multiple myeloma. Further research will be clarified to better understand the hyperdiploidy paradox. The third observation by the Heidelberg group was that the percent of malignant bone marrow plasma cells, as assessed by FISH, rather than flow cytometry as done by the Salamanca group, is associated with a hazard ratio of progression of 4.4. This finding is reminiscent of that of the Salamanca's group observation that patients with smoldering multiple myeloma or monoclonal gammopathy of undetermined significance, whose bone marrow plasma cell compartment is composed of 95% or more of aberrant flow phenotype plasma cells, have a 6.2-fold risk of progression to active myeloma. The Heidelberg group used the same cut point, but based their determination of normal and malignant plasma cells on the percent plasma cells with abnormal FISH and reported a hazard ratio for progression of 4.4. Fourth, the authors performed a multivariate analysis that solidified their observations, documenting that the prototypical high-risk FISH abnormalities, hazard ratio 1.6, hyperdiploidy by FISH, hazard ratio of 1.7, the proportion of malignant bone marrow plasma cells above 95%, hazard ratio of 3.4, and the Kyle model of high-risk smoldering myeloma, which includes both M protein greater than or equal to 30 grams per liter and bone marrow plasmacytosis greater than or equal to 10% as a surrogate for high tumor mass, hazard ratio of 2.8, were all independent predictors for time to progression. Immunoparesis and international staging system were not significant in this multivariate. Finally, they created several independent models combining high-risk FISH, excluding hyperdiploidy, and one of three definitions of high tumor burden. One, Kyle model, both M protein greater or equal to 30 grams and bone marrow plasmacytosis greater than or equal to 10%. Two, percentage of bone marrow plasma cells greater than 95%. And three, M protein of 20 gram per liter. In all models, the high-risk cytogenetics differentiated two prognostic groups in the low tumor burden group, but not in the high tumor burden group. Of these three models, the M protein of greater than 20 gram per liter as the high tumor burden category appeared to work best with the high-risk cytogenetics, but even here there were overlapping confidence intervals. An interesting point concerning all of these risk factors is that despite hazard ratios as high as 4, the 2-year risk of progression for any of these FISH abnormalities was 50% or less. In fact, if one extrapolates from their Kaplan-Meier curves, the respective 2-year times to progression were 50%, 35%, 30%, 25% for deletion 17p, translocation 414, hyperdiploidy, and addition 1q, respectively. These rates of 2-year progression are much lower than other risk factors identified by other authors, like bone marrow plasmacytosis above 60%, serum immunoglobulin free light chain above 100, and greater than 1 focal lesion on whole body MRI, all of which approach or exceed an 80% progression rate at 2 years. Although much of the study is confirmation of the Rajkumar paper published in Leukemia early this year, it offers 3 novel insights. First, 1q21 is prognostic in smoldering multiple myeloma. Second, determination of FISH risk status is most important in patients with low tumor burden. Third, estimating proportions of aberrant plasma cells using FISH is a potential alternative to flow cytometry estimation. Their confirmatory observation that deletion 17p, translocation 414, and hyperdiploidy are all risk factors for progression of smoldering myeloma is also very important. The take-home message of this work for general practitioners is that performing FISH is relevant in patients with smoldering myeloma to better understand a patient's risk of progression. The authors freely admit that high-risk FISH abnormalities are not yet an indication for instituting therapy, but can serve as additional stratification factors for prospective interventional clinical trials for those patients with the highest risk disease. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.